They're going to go back to the broker, and the broker's going to say, ah, that sounds crazy to me. But they don't know what you do, so yeah.
That's when I would say, tell the broker, we want to make you money. You know, if they get it, they'll understand. So incentivize them. Yeah.
You know, we ran into the same issue with the brokers in our area as well. I mean, they have a good deal right now going with where it's at, and we feel like we have to seek out with these brokers to work with these employers. But my prediction is as things continue to dissolve and get worse with health insurance in 2017 and 2018, I think they're going to seek us out because the buzz as DPC is here, it's growing, and it's happening, and doctors are taking back medicine. So these brokers are going to be looking for us. So we just got to basically create the foundation, the relationship, and stand steady.
On the back there.
So I'm not a juggernaut yet like FSMD, but I'm almost full, or at least I should be this winter.
Congratulations.
So now I know you did a podcast a year or two ago about hiring a doc or later bringing on a partner. And I've done that in traditional practice, but what are the things to watch for, or what are the common practices in hiring docs?
Sure. In fact, if anybody wants it, my PowerPoint for the AFP, American Cancer Family Physicians, their DPC summit in July, that was my topic, and it's the one time I've done a PowerPoint. Yeah, exactly. But the adding a provider, it's fantastic that we're at that stage, that's the conversation now too, is doctors are growing, they're seeing success, they're not eking out minimum existence for themselves, but it's expanding. The key thing with adding another provider is, first and foremost, it's about people. I love the show, The Profit. Anybody watch that? Yeah, all right, excellent. People, process, and product, right? We have a great process, we have a great product, now you have to hire great people. The hardest thing about finding that is the time. I'd rather have the right person at the wrong time than the wrong person at the right time. And that's easily the hardest. But after that is what value do they bring? For better, for worse, the conversation always goes to, what about mid-levels? I say, well, you know, mid-level can offer some value in some way. You can't find a doctor, mid-level's great. You're a male doctor, you need a female provider, mid-level's great. You want to do a more cosmetic side or nursing home side or whatever, whoever you bring on, you're looking at them as an expansion of your practice, whether that's equipment that provides new testing or a doctor that provides a new skill set. I think they might be a generalist too, that's okay, but you're looking for expanding your value proposition to patients, and I think if you look at it in terms of that, it's easier to know who to add or how to add them, but then how to pay them, we can talk about too. There's a lot of different ways to do that. I try not to pay my docs and keep them going.
Another in the back.
You said that you could make us experts in the self-funded plan in 2 minutes.
Yep.
Do that?
I regret that in my head.
He sets the bar really high, so I'm going to let him fall on his
I define expert really lowly though. So the simplest way to ever tell a self-funded policy, and I'll get a little technical and then get to the point. 99% of the time when you say self-funded, you mean partially self-funded. True self-funded is when a company says no insurance, we're taking all the money we charge our employees in terms of premiums, we keep it for ourselves, and we pay doctors and pharmacies and hospitals and hope that we don't go over. And if we do, then that money, hurts the company. And if we keep any money, we get 100% of the benefit. But we also have 100% of the control to, what doctors we allow in network or don't allow in network, etc. So you're not paying an insurance company to tell you no for an MRI. So 1% of companies will be that. You'll never worry about that. Partially self-funded equals, self-funded. And the idea here is it's a risk-sharing arrangement. The employer saying, I'm going to take on a little bit more effort, a little bit more risk. In exchange, the insurance company is going to give you better rates. So the 3 reasons that a self-funded plan is good for an employer. It's flexible, it's exempt from most of the Affordable Care Act, and they get money back. So if you remember those 3 things, flexible, avoids Obamacare, and they can get money back. So they're saving money, they're already interested, okay, good, you're speaking my language. If they say, what is self-funded? It is an HSA for a business. You get this much money to put into a bank account, that's your money. If that's not spent, you get it back. It's real simple. So if we could, I'd draw a pie, split the pie in the middle, and half is what we're going to call the claims pool for the employer. That's their HSA side, that's their money from their premiums. The other half, and this is how every insurance works basically, but in a fully funded regular insurance plan, the claims pool, you never get back. That just goes to Blue Cross, and they buy tall buildings, big lawyers, yeah. So the other half, we don't have to worry about too much, but it's good to understand what's happening there. And we'll just split it even 25-25. 25% goes to reinsurance. The insurance companies have insurance. So anytime, any big claim, they pick the number, let's say anything over $10,000, they send off to the Lords of London. They have a big insurance company that manages that, so they're never at a huge financial risk of $1 million claim coming in and wiping them out. That costs something, so that money's just gone. They lose that, they never get it back. The other 25% is their administrative cost, and anything left from their administrative cost is profit, like any business. So you're going to go to a smaller insurance company, a TPA, a third-party administrator. They're administering this insurance plan for the employer. and that administrative cost is where they have to excel at. And usually they're making a few percent off that. The insurance companies we've worked with the longest, Allied National out of Kansas City, they're in 14, 15 states with an insurance product for healthcare, have told us that their profits with our plans is 4 times higher than their next best plan. Why? Because we never send them anything, right? Yep. So what they realized, and this was that 5% of the conversation that was different for an insurance CEO, that this is why this is good for you. And he first said, family medicine isn't enough of our cost to cut out and take that risk. So you're absolutely right, because you're looking at DPC under the umbrella of just family medicine. But you have to look at it under the umbrella of everything we touch. Medicine, which is everything. Yeah, and actually there's a great video, Merritt Hawkins has a recruiting video out there about the top 5 most profitable specialties for a hospital. And number 1 is like orthopedic surgeon, and number 2 is family physician. $2.1 million in downstream revenue. So now that's hospital, but we're downstream revenue for the insurance company, medicines, labs, imaging, pathology, specialty referrals, our procedures, and when you send them a 99213 for an office visit, someone has to open it, touch it, say yes, say no twice. I send it back to you. You send it back to them. They say yes, say no again. And all that has a cost, and that's directly coming off their overhead. So when you say I'm doing unlimited visits, no copays, free procedures, wholesale meds, wholesale labs, they were paying $50 for an EKG before. No one's paying for an EKG now. And it's hard for them to get. So even the insurance company has a hard time understanding it. Just like some of the physicians here probably had a hard time, wow, I make more money seeing fewer patients. I don't get that, you know. But when they do, the employer starts to understand how all that works. The insurance agent starts to understand how all that works. And now they can lower the premium and actually make more profit because you changed their risk. They're not doing as much administrative. That was more than 2 minutes?
You're way over 2 minutes.
Okay. There was a joke.
I mean, you did a marvelous job.
Yeah, okay.
Marvelous job.
So, all that to say, self-funded plan, flexible, exempt from the Affordable Care Act, and you get money back. How do you get money back? That half, anything not spent, goes back. So as long as they don't make claims, if they don't go to the ER and spend $1,500 for a UTI, that money's still there at the end of the year. And that comes back to really the employees. So, you know, those 3 things, and that money goes back to the employees. If you know that much about a self-funded plan, you're sitting and talk out.
When you say tax shelter,
What's
is
that?
there a tax shelter for the employer?
The tax shelter is, they get the deduction for the health insurance premiums, and then when that comes back, if they take it as profit, they pay taxes on it. If they leave it and give it back to the employees, they don't pay any taxes on it.
How do the employers usually, in the insurance company, split what is not spent out of that pool? Is there some particular 50-50, or what usually happens?
Good question. How does the insurance company decide how much the employer gets? And that's based on the company. So some companies are going to be more generous, and some clinics are a little less generous, and that's just a competitive side. And then the self-funded part is so flexible that the employer has some say in that too. How much risk are we willing to take? Maybe a little bit the first year, and then when they have so few claims because of direct care, then they take a little bit more risk the next year. That's the benefit of self-funded, is they can design it to meet. And then, oh no, we have some really sick person, and we pull that back. We don't save as much, but we don't risk as much either.
What was the name of the company that you mentioned earlier?
Allied National is the one we've worked with, but any TPA insurance could do that for you.
Josh, they told me, Al told me also that if the bigger the company, then the more generously they split it with the employer. So if you only have a couple of employees, you don't get as big of a refund
Sure.
as if you've got 20 or 30 or.
Allied will go down to 2 employees. That's also an interesting thing. Most companies will say, oh, you have to be 50. Well, that was an old rule. The TPAs are getting a lot more flexible on that lower employer rate, except California, the USSR. California's weird in this regard.
And lots of regards.
Lots of regards. New York's the worst, but.
Questions?
Can you talk about the payment structure when you have, those of you who have more than one physician in your practice, and how you decided to do that, and kind of pros and cons of different ways to pay people?
I'm sorry, could you repeat the question? I'm sorry.
For those of you who have more than one physician,
yes,
how you
yeah.
pay,
Sorry.
how you each get paid?
Well, how my brother and I, who is my partner, it's always interesting to have your brother as your partner. But I get him and he gets me. But when what we do is we just divide by 50%, whatever after expenses, we just split it down the middle. Whether he had 407 patients and I have 450 patients, it's just fair in the end, So I think you just want to do what's fair. I think when you bring partners in, I think, looking at the employee versus partner, we've had to talk that we would just rather employ somebody than bringing somebody as a shareholder into our business, because now you got the third person, and then that creates some issues when trying to get things done. We're the ones that have the sweat equity. All of us who started these practices have taken the risk that nobody else wanted to do. And there was a lot of naysayers out there, and I think the naysayers are starting to see that this is a viable option of care, and it has a lot of integrity behind it. But from our standpoint, with Harry and I, we split everything right down the middle.
So this is also in my PowerPoint a little bit. The benefit is you can do anything you want. And sometimes that's just, what does the physician coming in want? I don't need 200,000, but I want to guarantee 120. Okay, well that's a little different. How do I structure that? Do you have a wait list? We just brought on a new doc and I have 100 patients too many on the other side of town. So where he's going to be joining, so we're going to filter those patients to him, hopefully, so that we don't even have to market those are in-house, and I can give him immediate payment. What we normally do, and this is what I think ends up being, in a lot of ways, logically the fairest to everybody, is no fee to join, because you're going to be an employee. I answered that too, because I think it's a great point. No cost of overhead, but not immediate payment. You keep what you kill. And you keep what you kill until you cap out at your salary per month, which for our doctors is $200,000 per year, and that usually hits between 350 and 400 patients, depending on age. Everything after that is mine. And then we get that question a lot, well, why would I see more than 400 patients? Because I wouldn't give you the job if you didn't. I mean, it's quite literal, but I don't make money until maybe 550, honestly, because I've got to pay my nurses, I've got to pay my rent, the startup costs, I'm going to do extra marketing for you, we're doing all your collections, we're giving you the amount you bring in, so if somebody doesn't pay, then we eat that. We're being very fair up front. The reason we don't bring on a partner, especially again, Doug, my partner, is still an employee for the clinic legally, because in the beginning we were 250, 300,000 in debt. So if he comes on, now he is owner at X% of that debt. So he's instantly poorer because he joined. And that might be great if I need the help paying for it, or if the doctor wants that. I really want to be a partner, I really want to pay. I want I want to lose money up front, pay you $50,000 now, so that later, because I think this is going to be huge. How hugest? Yeah, so huge. I can't tell you how huge it is. It's going to be great again. And so if they say,
That was inevitable. That was gonna happen. That was gonna happen.
It had to happen by me, after all.
It did. I walked into the hotel room the other night.
In the mirror,
I was like,
because they would have to say, I'm going to lose money up front, and I'm going to have less money going forward, and more effort, more risk, more everything, more responsibility, because later maybe Dr. 3, 4, and 5 come on as employees, and they get a piece of that. If they really want that and they're the right person, then you have to make that decision. I think most of us would say, looking at the work, I'd rather be an employee. It's an exponential amount more work for the effort and the stress. So often it is probably better to just make an employee, and then they can leave easier. You always write a contract with an exit clause. Every marriage ends by death or divorce. My dad's a lawyer, so of course, contracts. And that just makes it easy. When you get out, how do you get out? We decide all this up front when we're friends, not on the back end when we're mad at each other. So you have no equity, I keep your patience, there's a non-compete or there's not. We decide that up front as an employee. Keep it simple, you don't have to go crazy, complex with a lawyer, but it's nice to have that stated. So then the doctor on the keep what you kill, I think it also changes their mindset from the insurance model where I'm full, I don't have to make people happy necessarily, yada yada, to all right, this is it. I've got to keep people happy and make the phone calls and follow up with them and grow my practice and go to the chamber meetings and shake babies and kiss hands and do the whole Senator Colbert thing. To grow that, and then they're invested in it, and if they grow slow, that's a little bit their fault. You didn't promise them rapid growth, but if they grow really fast, good for everybody.
Yeah.
Yes, Jan Pigeon-Asking, an internist. I've done hospice medicine, urgent care, I do a little conscious sedation. I see a lot of patients. I'm working actually in a pain clinic now. I'm trying to build a DPC practice. And my question is, being that, like this gentleman to my left, a fellow internist, he said he went through all trying to get people. I've tried everything. I've tried advertising, sign, cards, word of mouth. But the thing that's dawned upon me is that word of mouth is one thing once you get going. But for example, I'm working in a pain clinic to build that practice, and I had to switch offices 3 weeks ago, and 8 or 10 of the people I left, I said, you can come see me at the other office, it's an hour away. They're like, where's your office, I mean, that's maybe a little legal, but the point is that I think sometimes when you're in to build your practice, why don't we as physicians, as a hospice I would do that, in the ER, I've gone to also the one ER and one urgent care. Those are the people, that may be an avenue there to get patients, because I think, and that's my question to you guys, to get aggressive, to go to the ER at the 2 hospitals that I'm surrounded about, to the urgent care, bring them donuts, put on my drug wrap suit, and whatever I have.
You're trying to get different referral sources.
Yeah, and I think that for people who are trying to get going, I'm amazed at what this gentleman's tried with all the avenues we have for advertising and drawing people in. I think sometimes if we could go to maybe the administrator of the hospital, even though they may be an adversary, and say, hey, look, this patient went through your ER, just cost you $2,200. And, instead of that, one of the salient features of direct primary care is that patients are kept out of the hospital 83% of the time is a statistic that I read. If you could get to those people, the urgent care heads, say there's 5 or 6 urgent cares in your neighborhood, there's 2 hospitals in your neighborhood, and then the other things I keep talking, Lions Club and those things.
Yeah.
So that's my question to you. I always think of it as that gap that's there, like Netflix. Who wants to watch Blues Brothers and all these movies for a million times? when you just want to watch 10 movies, anyway.
Yeah. This might be too universal a statement, but I haven't found a bad referral source yet. I mean, if a patient finds us, that's awesome. I think when you're dealing with other businesses, you have to consider their motivations, and that's tricky. If you have an ER that will refer you patients, that's awesome. In fact, my biggest referral source for the first 2 years in practice was the 2 other safety net clinics in town. So, you know, people lay safety net clinics. One was a community health center, and one was kind of mostly funded by the hospital.
But with this economy, aren't a lot of those, you know, I mean, if you start...
Well, and the question is why were they referring them to me? Well, they had their own little guidelines, and people didn't have the right paperwork, and they made $5 too much per year. They didn't qualify for their, you know, these people they didn't have money, but they were often uninsured. So, you know, so that was a great referral source for me, but it kind of depends. The urgent care thing, that would be tricky because their whole business model is based on seeing 70 patients a day. They say they don't want to do primary care. I mean, Walgreens states they're not primary care and they don't want to cut you out, but I mean, their business motivation, I would say, is to see more patients. Now, maybe an ER, if you had the right people in place, maybe, and that's awesome if you can accomplish that, but that's a much bigger task than going around and talking to, you know, 10 people in the Lions Club about diabetes. I mean, that's an easy thing to do. Now, getting into like talking to hospital administrators is tougher if you have that connection to do it. But I think it gets trickier when you start getting into referral sources that may have competing business interests.
Have any of you guys done that, gone directly to an ER, to an urgent care?
I know the charge nurse at the ER very well socially, and she loves this. I take care of a lot of her family. I don't get many referrals from the ER.
And one last comment on that, I'm sorry. You know, being a hospitalist, there was something called red button at the end of an admission.
I'm just hoping they tell me when my patients go there.
Yeah. At the end of admission, you know, a patient comes in unassigned, and there's a ratio, or who gets this patient on Monday, Tuesday, Wednesday, who gets that. I mean, that would be an option.
Yeah,
also.
I mean, if that works for you at your community hospital, that's an awesome. If that works out, that's awesome. I don't know if that's a great source in every community, but if that works for you, that's awesome.
Can I respond to that? So we are half a block away from the hospital. It's a community hospital, primarily underserved. All the ER docs know me because I also work at the residency. All the internists, all the hospitalist group know me. I get patients in the same day or the next day from follow-up in the ER or from the hospital, and they love it. I get 3 patients a week from ER or hospital follow-up. They also send their folks that are uninsured, unassigned to follow-up clinic, and then they try to push people to the different places in town, and I'm the easiest one to get into. So this is a perfect place, especially if you're in the underserved part of your community or desiring to care for that population, to pick up patients. Now, be careful though, because they're complicated, and they're coming out of a hospital.
Triple digit.
So you've got to be ready to deal with people. And if you want to be that person, then that's a great setup. So
Just wanted to follow up. Early in my hospital's career, 38-year-old guy would come in with no problems, and 3 days later, he's got high cholesterol, he's got coronary artery disease, he's got hypertension, he's got obesity, problems that need to be addressed. There's 4 problems right there. Forget the billing, just the care of that patient.
Yeah.
One of the things I was going to say is in my hometown, I trained in my hometown and did my residency there. So our name is pretty well known in the community, and my granddad was a GP, practiced 39 years in Erie. And the advantage of doing my residency at one of the 2 major health systems was that all the staff know me, the nurses, the ER docs, even hospitalists. And a lot of times we'll get referrals back through the system because the patient's been in and out maybe 2 or 3 times in 8 to 10 weeks, and they said they're not getting follow-up, and then our name will get dropped, and so we'll get those patients that way. They have insurance. I mean, 95% of my patients have insurance, and 5% are uninsured. So I think there's a lot of opportunities, but I think the advantage is that when we look at how the demographics falls out for residency training, when physicians graduate from their programs, where do they relocate? For us, it was a good thing because we stayed home. People knew our name. Now, if you're going outside to another area or you're going back home, you're going to have some of those intrinsic benefits of having a name that's known and establishing a professional rapport to get those new patients coming in.
Sure.
question about employees, because I've done a lot of marketing. I'm launching my DPC practice, and I hear my staff answering the phone, and it's somebody looking for a doctor, and they just don't really know what to tell them. And I've tried to coach them through it, and I don't know if they, I don't know if you have some.
How many employees do you have?
So I have 3 employees, which I'm not going to lose because my husband is a psychiatrist. He already runs a cash practice, and we share our employees.
Yeah.
So I need to keep all 3 employees, but at the same time, I think I've heard them receive phone calls and then it doesn't convert into a patient. And I'm
Well,
not sure how to make them.
some people are not naturally good at some of those type of things. So I mean, some of it depends on the person and their personality. They may feel very uncomfortable with that, even if they know all the ins and outs of your practice. Luckily, I only have 1 nurse. I've had 2 nurses now. One's a med student. But so whenever my nurses have started with me, I actually didn't let them answer the phone for about 2 weeks. And I made them sit and listen to me. And you know, they eventually buy in. They're not as passionate as I was. But they heard my spiel to new patients 5 or 10 times. I think the advice I would give to them is make it a conversation. So whenever someone calls in, almost regardless of why they're calling or what their first question is say, how did you find us? And what are you looking for?
Right.
And it's a natural conversation. So if someone says, I think I have a UTI, say, okay, that's great. Here's what we would do for your UTI. So it's hard to know who's on the other end of the phone without asking a few questions. And so if the person answering the phone feels like they're a used car salesman, they're going to act very awkward and feel uncomfortable doing that. But if you just get into a conversation and say, oh, that's great. Actually, our patients don't pay for dipstick UAs, and they pay $10 for a culture, free strep test, or whatever it is they might be calling about. I think it's a lot easier for people to have that conversation than feeling like they're selling something.
One thing I wanted to add is, we did a lot of training with, we have 2 full-time employees in my front office girl. She has been with us since the beginning when we were insurance-based and making the conversion over. But as I consult with other practices about making the transition into the DPC model, they ask that very same question. How do you get your phones so people understand what you're selling? I welcome any of you guys to call my office and talk to Melinda as if you were a prospective patient and record it.
My nurse would love that too. I'll volunteer my nurse for that.
It's like secret shoppers. I mean, it's actually
that's a great idea.
It's 814-864-3749. Is Vicky Family Medicine Erie.
Yeah.
It's IZVICKI.
That's a great idea. Yeah. That's a really
It
good idea.
just gives you, and she does such a wonderful job, and she captures so many patients for us versus my medical assistant.
Don't call Monday morning.
Yeah.
Well, I would say if you have someone who you do not feel comfortable with, don't have them answer the phone.
Absolutely.
I mean, that seems like a hard thing because you're trying to delegate tasks, but I mean, if you miss a patient, I mean, that's a huge
And
deal.
here's an old adage.
Give them a job where they're not on the phone.
You control the phones, you control the business. It's that simple, folks.
I answer my phone still about, I have
Always
a whole
answer
channel.
phone, yeah.
I answer them, my nurse and I take a big race to answer the phone. It's a big joke.
It's a culture.
So I probably answer my phone probably about a third of the time. It used to be 70% of the time, even when I was close to full. But so yeah, you can still answer your own phone. I mean, if you can't answer your phone, sometimes it probably means you're not structured right, I would say.
Yeah, absolutely. I would say, and I'm going to be bold, and this is going to come off, of course, it's your fault. And it has to be, you have to put that on your shoulders. So we don't take that, because we're not always the owners of the business, it's a hospital, it's someone else. And now we're in the ownership role. We're the boss, and we can forget that. And if they're not doing it well, I mean, this is kind of art of war. If the soldiers are bad, you cut off the general's head. Because they're the leader. So, and it doesn't mean you fire them. You find out what they're good at and change the role, or say that wasn't great. And we're going to get better at it every time. And I can tell you exactly what my nurses are thinking by the way they pitch it. Like, it wasn't a good patient. You can almost say that was a drug seeker. They're like, yeah, it's like $75 a month and stuff. You just weren't even trying. Because you guys prescribe Vortex, and stuff. Versus the full on, oh, you love it and this. So sit down, have a conversation. First thing every day, practice.